Welcome to The Funnel Effect. Today we are exploring a 2026 state-of-the-art review from Eurointervention titled Pretreatment with Antiplatelet Agents in Patients Undergoing Coronary Revascularization, authored by Gerline Kaur, Angela Oliva, Roxana Marin, and Deepak L. Bhatt from the Mount Sinai Fuster Heart Hospital and Harvard Medical School.
Thank you. It is honestly a remarkable piece of literature. What these authors have managed to do is, well, they've synthesized an evolution or maybe a full-on revolution in how we handle one of the most critical emergencies in all of medicine.
Yeah, and to really grasp the weight of this review, I want you, the listener, to imagine a scenario. Just imagine a paramedic is standing in your living room and they're holding a life-saving pill.
Right. A very common scenario.
Exactly. You are having a heart attack. Common sense and honestly just basic human instinct screams at that paramedic to give you the pill immediately, right? Bust the clot, restore the blood flow, save the heart muscle.
That is the instinct. Absolutely.
But a massive tectonic shift in global cardiology guidelines has revealed a terrifying reality. Giving that exact pill 1 hour too early could actually turn a routine, life-saving procedure into a fatal surgery.
I mean, it completely shatters that fundamental medical instinct we all grew up with, that in-and-out urgency earlier is inherently better.
Right.
For decades, the default stance in emergency cardiology was just to hit the clot as hard and as fast as possible.
Because why wouldn't you? It's a clot.
Exactly. But this 2026 paper maps out how the very systems we built to save lives, like the incredibly fast modern hospital networks, actually change the mathematical reality of how these drugs interact with human physiology.
Wow.
Yeah, we are walking a razor's edge here between preventing a fatal clot and inadvertently causing a catastrophic hemorrhage.
Okay, let's get our terminology locked in because the medical community uses a very specific word for this dilemma, and that word is pretreatment.
Right, pretreatment.
And I want to be incredibly precise here because we aren't just talking about giving someone an aspirin on the way to the hospital.
Well, not at all.
When this paper discusses the dangers and benefits of pretreatment, what specific biochemical mechanism are we actually targeting?
So, when cardiologists use the word pretreatment in this specific context, they are referring to the administration of oral P2Y12 inhibitors.
Okay, so heavy-duty stuff.
Very heavy duty. These are potent blood thinners. We're talking about drugs like clopidogrel, ticagrelor, and prasugrel.
Right.
And the defining characteristic of pretreatment is that you are giving these powerful agents before the coronary anatomy has been physically mapped out.
And by mapped out, we mean before the interventional cardiologist has threaded a catheter up into the heart, injected that contrast dye, and looked at the angiogram to see the actual plumbing.
Correct. The angiogram is essentially the roadmap. It tells the surgical team exactly where the blockage is.
Whether it's like a soft, fresh clot or a heavily calcified plaque.
Right. Exactly. And crucially, what the surrounding vascular architecture looks like. So pretreatment is the clinical decision to administer those potent oral blood thinners blindly.
Blindly. That's the scary part.
It is. You're doing it in the back of the ambulance or maybe in the ER of a small community hospital before anyone has actually laid eyes on the physical structure of the patient's heart.
Which, I mean, that feels like a massive leap of faith.
Oh, it's a huge leap of faith.
But there has to be a compelling biological reason why thousands of doctors thought flying blind was the right call. I know the review lays out a detailed physiological tug-of-war, specifically in Figure 1.
Yes, Figure 1 really breaks it down beautifully.
Right. So if we are taking that leap of faith to give the drug early, what biological advantage are we actually trying to secure?
It fundamentally comes down to the pharmacokinetics of oral medication, specifically how long it takes a pill to actually start working.
Because it's not instant.
Far from it. If you hand a patient a pill of ticagrelor, that medication has to travel down the esophagus, dissolve in the highly acidic environment of the stomach, pass into the intestines, get absorbed across the gut wall.
Right, into the portal circulation.
Exactly. And then for some of these drugs, it has to be metabolically activated by the liver before it ever reaches a single platelet.
That is a massive biological commute.
It's a huge commute. It can take several hours to achieve maximum platelet inhibition. So the historical logic was honestly pretty simple.
Like, give it early so it has time to work.
Exactly. We know this patient is likely going to the catheterization lab. We know the cardiologist is going to inflate a high-pressure balloon in their artery and deploy a metal stent.
Which is traumatic for the vessel.
Very. That physical trauma to the blood vessel wall is highly thrombogenic. It actively triggers the blood to clot.
Oh, wow.
So if we wait until the patient is on the operating table to give the pill, Their blood won't actually be thin until long after the procedure is over.
So the strategy is purely about buying time. You give the pill in the ambulance so that the hours-long biological commute happens while the patient is, sitting in traffic or waiting in the ER.
Exactly.
And by the time the doctor is placing the metal stent, the drug has finally reached the bloodstream, the platelets are chemically disabled, and you've built this shield against periprocedural clots.
That is the exact physiological advantage. It provides a robust shield of ischemic protection during the most vulnerable window of the procedure.
It's like the ultimate plumber's dilemma.
A plumber's dilemma.
Yeah, think about it. You've got a sink backing up, and you're pouring gallons of heavy industrial chemical drain cleaner down the pipes before the plumber even arrives with a camera.
Oh, I see where you're going with this.
Right. You are assuming it's just a simple hair clog, and those chemicals are going to get a fantastic head start on dissolving it.
But if the plumber arrives, puts the camera down the drain, and realizes the pipes are completely rusted through and shattered.
Exactly. Then a simple sneak isn't going to fix it. They have to cut open the walls and replace the entire plumbing system.
That's a great analogy.
And now they have to saw into pipes that you just flooded with boiling toxic chemicals. That premature assumption just made the necessary reconstruction incredibly dangerous.
It really did.
That has to be the nightmare scenario for the cardiologist looking at that angiogram.
It is the absolute clinical nightmare this paper addresses. The patient arrives, they've been pretreated with a heavy dose of clopidogrel or ticagrelor.
Right.
The interventional cardiologist gets the camera in there and immediately sees that a stent cannot fix the problem.
Like it's just too far gone.
Yeah, perhaps there is complex multivessel disease,
Right.
or perhaps the left main coronary artery, the primary pipeline for the entire heart is critically narrowed in a way that stenting would be futile or even fatal.
Meaning they need immediate open heart surgery, a coronary artery bypass graft.
Yes. They need a CABG. But the cardiac surgeons are now staring at a patient whose platelets have been chemically paralyzed.
No.
To perform a bypass, surgeons have to crack the chest, put the patient on a cardiopulmonary bypass machine, and meticulously sew delicate new blood vessels onto the heart.
And if the blood is totally thinned out?
If the blood has been heavily thinned with irreversible or long-acting agents, the bleeding risk during that surgery becomes astronomical.
So the surgeons are just forced to wait.
They have to. You have a patient with critically starved heart tissue, and they just have to sit in a hospital bed for days while the medical team waits for the patient's body to naturally wash the drugs out of their system.
That is horrifying. They sit there actively bleeding internally or at severe risk of further ischemic events, simply waiting for the pharmacology to wear off.
Exactly. And we haven't even touched on the most basic disadvantage here, misdiagnosis.
What do you mean? Like, what if they don't even have a heart blockage?
Right. What if the angiogram shows pristine, perfectly healthy coronary arteries?
Oh, wow. Because chest pain can be like a dozen different things.
Exactly. It could be an aortic dissection, which is a tear in the major blood vessel where giving blood thinners is essentially a death sentence.
Oh, my. Yeah.
Or it could be a severe esophageal spasm or acute pericarditis. In those cases, you have exposed the patient to powerful systemic bleeding risks for absolutely zero cardiovascular benefit.
This theoretical plumbing danger isn't just a speculative academic debate, is it?
Not at all.
The Euro intervention paper meticulously documents how this exact catastrophe played out in real-world data for a massive subset of patients, and that ultimately forced this unprecedented U-turn in global medical guidelines.
It did. But to understand that U-turn, we have to look at how we actually categorize heart events.
Right. The data forces us to divide acute coronary syndromes into two distinct clinical pathways based on the initial electrocardiogram, the ECG.
Correct. The first, and arguably the most complex regarding this whole pretreatment debate, is NSTE-ACS.
Okay, so NSTE-ACS, we're distinguishing here between STE-ACS, the partial occlusions, and a full STEMI.
Yes, that's the key distinction.
Let's look at how the pretreatment math changes for those partial blockages first. Just to ground us, when the guidelines say NSTE-ACS, what physical reality in the heart muscle are we actually talking about?
We are talking about a compromised but not entirely severed supply line. So NSTE-ACS stands for non-ST segment elevation acute coronary syndrome.
That's a mouthful.
It is. But it basically encompasses unstable angina, where the heart muscle is screaming for oxygen but hasn't sustained permanent cellular death yet.
Right.
And it also includes non-ST elevation myocardial infarctions, where some tissue has died, but blood is still physically squeezing past the ruptured plaque.
So it's a critical emergency, but the pipe isn't cemented shut. It's a trickle, not a dam.
Precisely. And it is within this specific population, the patients with the trickle, that the medical community experienced a whiplash-inducing paradigm shift.
Whiplash is right.
If we look at the European Society of Cardiology guidelines, the historical pivot is just staggering. In 2018, the ESC evaluated the data and gave routine pretreatment in NSTE-ACS a Class 3 recommendation.
Okay, Class C essentially means the weight of evidence says you should probably do this, correct?
Yes. It basically meant the systemic benefits outweighed the risks. The prevailing wisdom was, once you establish the diagnosis of a partial blockage, get the P2Y12 inhibitor on board immediately.
Right, get that shield up.
Exactly. But fast forward a mere 5 years. In the 2023 ESC guidelines, that recommendation didn't just quietly fade out, it plummeted to a Class 3.
Wait, a Class 3 is a definitive do not do this, right? That is a literal warning label.
It is an active recommendation against the practice. The 2023 guidelines explicitly stated that routine pretreatment with a P2Y12 inhibitor is not recommended in NSTE-ACS patients, where the coronary anatomy is unknown and an early invasive management strategy is planned.
I have to pause here because that timeline is jarring. 5 years.
It's nothing.
In the grand scheme of medical history, 5 years is a blink. I mean, human biology didn't fundamentally alter itself between 2018 and 2023.
No, the platelets didn't suddenly mutate.
So how did a treatment strategy go from standard life-saving medicine to potentially harmful malpractice in half a decade?
The biology remained constant, but the ecosystems surrounding the biology underwent a radical optimization.
The hospital systems.
Exactly. To see how that happened, we have to forensically examine the trial data. We have to start with the early foundational studies that convinced us pretreatment worked in the first place.
Okay, let's go back.
The original dogma was heavily anchored in a landmark 2001 trial called PCI-CUR.
So we are rewinding to the early 2000s. What did PCI-QRE actually measure, and why did it make everyone fall in love with giving pills early?
So PCI-CURE focused on pretreatment with clopidogrel. They compared it to a placebo in patients with non-ST elevation events who were scheduled to undergo percutaneous coronary intervention, or PCI.
Basically getting a stent.
Right. And the top-line results were spectacular. They demonstrated a 31% reduction in cardiovascular death or myocardial infarction in the pretreated group.
Wow. A 31% drop is massive.
Yeah.
If I'm a cardiologist reading that in 2001, I'm ordering clopidogrel for every single patient the absolute second they hit the ER doors.
And that is exactly what the global cardiology community did, but there was a hidden variable in the methodology of PCI-CRE that wouldn't become obvious until years later.
A hidden variable.
We have to look at the median time from when a patient was randomized in the trial to when they actually rolled into the catheterization lab for their angiogram.
Oh, how long were they waiting?
6 days.
6 days. Wait, so these patients are lying in a hospital bed with a partially blocked artery for almost a week before anyone puts a camera in there.
Almost a full week. But you have to remember that was the reality of medical infrastructure at the time.
Right, 2001.
Catheterization labs were scarce, scheduling was incredibly complex, and interhospital transfers were just slow. Now, apply the pharmacology to that timeline.
Okay, if you have 6 days of sitting around with an unstable plaque in your heart, of course giving a powerful blood thinner early is going to be beneficial.
Exactly. You are utilizing those 6 days to allow the drug to slowly reach maximum efficacy. It stabilizes the volatile plaque and prevents a secondary clot from forming while the patient waits for an open slot in the operating room.
So the drug wasn't necessarily a magic bullet. It was just a fantastic patch for a very slow, inefficient medical system.
That's a perfect way to phrase it.
But, I mean, if I show up at a major metropolitan hospital today with a partial blockage, I am absolutely not waiting 6 days to see a cath lab.
You might not even wait 6 hours. Modern hospital systems have developed incredibly efficient, rapid response heart teams. Door-to-balloon times have plummeted globally.
And that Kincrease speed completely broke the mathematical foundation of pretreatment, didn't it?
It absolutely shattered it. When researchers began running new clinical trials to test these drugs in the fast-paced modern era, the results didn't just look different, they looked alarming.
The review highlights a few of these modern reality checks, like Armida-5, ISO-React-5, and Dubious. Let's look at ISO-React-5 because the contrast is stark.
ISAR-REACT 5, which was published in 2019, was a massive, highly anticipated trial involving over 4,000 patients.
Okay.
They directly compared giving ticagrelor as a blind pretreatment against a strategy of waiting and giving prasugrel only after the coronary anatomy was visualized.
So early pill versus wait and see.
Yes. And in this modern trial, the average time between the patient receiving the drug and getting the angiogram wasn't 6 days.
What was it?
It was 61 minutes.
61 minutes. We have compressed a week of waiting into a single hour. When the window is that tight, did the early pill still provide that 31% protective shield we saw in 2001?
It provided zero additional benefit.
Zero.
Zero. When the systemic delay was erased, the early pill did absolutely nothing to reduce the rate of death, myocardial infarction, or stroke in these NSTE-ACS patients.
That's incredible.
And the Dubious trial, which looked at a similar modern time frame, corroborated this perfectly. Routine pretreatment yielded no significant reduction in ischemic events.
So the benefit just evaporated. But a lack of benefit isn't enough to drop a guideline to a class 3 do not do this warning. There must have been active harm occurring.
There was. And the trial that truly served as the smoking gun, the one that terrified the medical community into rethinking everything, was the ACOAST trial.
Walk me through ACOAST. Why was it so frightening?
ACOAST was published in 2013, and it looked at over 4,000 NSTE-ACS patients who were scheduled to undergo an angiogram within a rapid 2 to 48-hour window.
Okay, modern timeline.
Yes. They focused on prasugrel, which is a very potent P2Y12 inhibitor. They split the patients. Half received the drug blindly upstream as pretreatment, and the other half only received it downstream exactly at the time of the PCI once the doctor had the camera in the artery.
Let me guess. Zero benefit for the early group.
Zero benefit. No reduction in ischemic events, no difference in the size or burden of the thrombus, no decrease in the need for urgent revascularization.
Right, but what about the harm?
When the researchers looked at the safety endpoints, the data was glaring. The patients who received the drug early, blindly, suffered double the risk of major bleeding complications compared to the group that waited.
Double the risk. Oh my God.
Blah.
So because our hospitals evolved and became highly efficient at transporting patients from the ER door to the operating room, a drug protocol that genuinely saved lives in 2001 mutated into a protocol that just subjected people to severe, sometimes fatal bleeding risks with absolutely zero upside.
It is one of the most fascinating examples of systemic evolution unmasking a clinical vulnerability.
Unmasking it how?
Well, we optimized the hospital flow so thoroughly that the head start provided by the oral drugs was no longer required to stop clots. However, the biological duration of those drugs, the fact that they stay in the system for hours or days, was still long enough to trigger catastrophic bleeding if the angiogram revealed the patient actually needed a bypass surgery instead of a stent.
Oh.
The speed of the modern hospital stripped away the benefits of pre-treatment, leaving only the unmitigated risks.
This perfectly highlights why this 2026 Euro Intervention Review is so vital. It's forcing us to update our mental models.
It is.
So let's translate this into actionable reality for the listener. If someone is sitting in the ER and they are told they have a minor heart attack, an NSTE-ACS, and the attending physician says they are prepping the cath lab for a quick intervention, what does the data dictate should happen with those blood-thinning pills?
If the intervention is happening quickly, specifically within 24 hours, the data is unambiguous. You hold the pill.
You wait.
You wait until the interventional cardiologist has visualized the coronary anatomy. The 2023 ESC guidelines are ironclad on this.
Are there any exceptions?
The only clinical scenario where the guidelines suggest pretreatment might still be considered, and even then it's a weak class I recommendation, is if the patient is stranded in a remote, non-PCI capable hospital.
So if they have to be transferred.
Right, and the logistics dictate that their transfer to a major cardiac center is going to take longer than 24 hours.
Because in that specific remote scenario, you have essentially time traveled back to the early 2000s. The systemic delay has returned, so the slow-acting pill regains its utility.
Precisely. If the system is fast, you rely on the speed of the system. If the system is slow, you rely on the pharmacology of the pill.
That elegantly covers the partial blockages. But the calculus has to change when the situation escalates.
Oh, absolutely.
What happens when the pipe isn't just trickling, but is completely catastrophically cemented shut, and the heart muscle is dying by the minute?
That brings us to the second major category of our discussion, STEMI. ST segment elevation myocardial infarction.
This is the classic widowmaker.
Yeah.
The massive, crushing chest pain.
This is the absolute apex of medical emergencies. In a STEMI, the coronary artery is 100% occluded. There is zero blood flow getting past the rupture.
None.
None. And every single minute that ticks by, millions of cardiac cells are undergoing irreversible necrosis. The tissue is dying.
Given the sheer severity of a STEMI, I assume the guidelines regarding pre-treatment are significantly more aggressive than the wait-and-see approach we just discussed for partial blockages.
They are more aggressive, but they are also layered with a frustrating amount of ambiguity.
Ambiguity? How so?
Well, for STEMI patients, both the American and European guidelines maintain a very strong Class I recommendation to administer a loading dose of a P2Y12 inhibitor. There is no debate that the drug is medically necessary.
Right.
However, the guidelines remain conspicuously vague on the precise timing of that administration.
Wait, really?
Yeah.
Yeah.
They do not draw a definitive line in the sand regarding whether the pill must be swallowed in the ambulance or if the paramedics should wait until the patient crosses the threshold of the hospital doors.
Why the hesitation? I mean, if the artery is completely blocked, why aren't the guidelines screaming at paramedics to shove the pill down the patient's throat the millisecond they see the ECG?
It's a fair question.
Why is the risk tolerance different here compared to the NSTE-ACS group?
It comes down to a shift in the physiological probabilities. In a STEMI, the clot burden, the actual physical mass of the thrombus inside the artery, is massive.
And highly volatile.
Highly volatile. Furthermore, because the artery is totally blocked, the anatomical reality is that almost every single one of these patients is going to require an immediate primary percutaneous coronary intervention.
A stent.
Yes. They need a wire pushed through the clot, a balloon inflated, and a stent deployed right then and there.
Ah, I see. So the plumber sketch 22 from earlier, the terror of finding out the patient needs open heart bypass surgery instead of a simple stent, is largely removed from the equation.
Exactly. Very, very few STEMI patients are rushed directly from the ER door into an open heart CABG surgery, and virtually none are treated with medical therapy alone.
That makes sense.
The statistical likelihood that you will accidentally induce irreversible chemical bleeding in the patient who requires an emergency surgical bypass is incredibly low.
So the penalty for guessing wrong is lower.
Right. Therefore, the risk penalty for administering the pill early is drastically reduced, while the potential reward initiating the breakdown of a massive heart-killing clot is theoretically immense.
The theory makes perfect logical sense. You have a massive clot, very little surgical risk, so throw the drugs at it early.
Right.
But if we learned anything from the partial blockages, it's that theory often crumbles when subjected to modern trial data. Does giving the pill in the ambulance actually translate to save lives for STEMI patients?
This is where the narrative becomes incredibly nuanced and frankly a bit of a medical mystery.
Well,
Let's look at the historical data first. In 2005, the PCI Clarity trial investigated clopidogrel pretreatment specifically in STEMI patients.
and how did that go?
The results were a resounding success. They saw a 46% reduction in the odds of cardiovascular death or recurrent myocardial infarction.
Okay, but wait, 2005, let me apply the lesson we just learned. If PCI Clarity was conducted in 2005, what was the systemic delay? How long were these total blockage patients waiting?
Your intuition is spot on. In PCI Clarity, the median time to PCI was 3 days.
3 days.
Yes. They were receiving fibrinolytic therapy. Those are powerful clot-dissolving drugs, but they were still waiting days for the physical angiogram.
Okay, so it was an older trial reflecting an older, slower therapeutic reality.
Exactly.
We need a modern trial.
Yeah.
We need to see what happens when you give the pill in the ambulance for a STEMI, but the hospital is ready and waiting to operate immediately.
For that, the Euro Intervention Review points us to the Atlantic trial, published in 2014, and this study is fascinating in its design.
How was it set up?
They enrolled over 1,800 patients experiencing an acute STEMI. They randomized them into 2 highly controlled groups.
Go ahead.
One group swallowed the active ticagrelor pill in the back of the ambulance. The other group swallowed a placebo in the ambulance and didn't receive the active drug until their stretcher rolled into the hospital catheterization lab.
How tight was the time difference between the ambulance group and the hospital group?
On average, the difference in drug administration was only 48 minutes.
48 minutes. In a total occlusion, 48 minutes of zero oxygen is catastrophic for the heart muscle. Surely, getting a 48-minute head start on dissolving that clot with ticagrelor provided a massive advantage.
That was the expectation. Everyone thought the early pill would be a game changer,
Yeah.
but the reality was a statistical flatline. For the primary endpoints of the trial, giving the drug in the ambulance failed entirely.
It failed.
It failed to show any significant difference in resolving the ST segment elevation on the ECG before the procedure, and it completely failed to show any improvement in restoring physical blood flow through the artery before the stent was placed.
Hold on. Giving the drug early didn't open the artery any better.
Yeah.
The 48-minute head start did absolutely nothing.
Nothing for the acute, immediate resolution of the blockage.
Wow.
The only metric where the ambulance group showed a statistically significant benefit was a secondary endpoint, a reduction in stent thrombosis at 30 days.
Okay, meaning what exactly?
Meaning, the patients who got the pill in the ambulance had a slightly lower risk of a new clot forming on the metal struts of the stent a full month later.
Oh,
But in terms of the immediate crisis saving the dying heart muscle in that very moment, it was a wash.
why? That defies logic. We know ticagrelor is an incredibly powerful drug. We know the artery is full of clot. If you introduce the drug earlier, why on earth wouldn't it show a better physiological result right away?
Here is where the science gets deeply, beautifully complicated. And this is a wild physiological variable that the Atlantic trial investigators basically stumbled upon during their analysis.
I'm listening.
The failure of the early pill had almost nothing to do with the heart and everything to do with another drug entirely, morphine.
Morphine, like the intravenous painkiller.
Yes, morphine. Think about the physical reality of a massive heart attack.
The pain must be unimaginable.
Exactly. The patient is experiencing excruciating, crushing, visceral agony. It is standard, humane, emergency protocol for paramedics to administer intravenous morphine to alleviate that suffering.
That makes total sense.
Right. And it also reduces the sympathetic nervous system's overdrive, lowering the heart rate and decreasing the oxygen demand on the struggling heart.
So it's good for the patient.
It is. But opioids like morphine have a very specific, profound side effect on the human body. They bind to mu-opioid receptors in the gastrointestinal tract, which severely slows down peristalsis. It drastically delays gastric emptying.
Wait, meaning the morphine essentially puts the entire stomach and digestive tract to sleep.
Exactly. The gut effectively goes offline.
Oh my God.
So visualize the sequence of events in the ambulance. The paramedic, acting correctly, gives the patient IV morphine for the crushing pain. 10 minutes later, they hand the patient a ticagrelor pill to swallow, hoping to get that 48-minute head start.
And the patient swallows it.
The patient swallows the pill. But because the stomach is chemically paralyzed by the morphine, and because the body is generally in a state of profound cardiogenic shock.
Where the brain is frantically shunting blood away from non-essential organs, right?
Yeah.
Yes, to protect the heart and lungs. Because of all that, that pill does absolutely nothing.
It just sits there.
It just sits there in a pool of static stomach fluid. It is undigested. It is unabsorbed. It never makes it across the intestinal wall. It never enters the portal vein, and it never reaches the platelets in the bloodstream.
I am stunned by that. We are giving them a pill in the ambulance, looking at our watches, thinking we are executing a brilliant 48-minute pharmacological head start.
Yep.
But because their body is in systemic shock, and because we flooded them with necessary painkillers, their stomach is completely shut down.
Yeah.
We are literally sending a life preserver in the mail to someone who is actively drowning.
That is exactly the biological reality. We were relying on a slow, complex oral delivery mechanism in a patient whose entire digestive system was fundamentally turned off.
Wow.
The Atlantic trial data revealed a massive, significant interaction between morphine administration and the failure of early ticagrelor. If they got morphine, the early pill was useless.
This physiological roadblock, the realization that the gut is completely unreliable during a major cardiac event, is the perfect pivot for this review.
It really is.
It tells us that the entire debate over pretreatment isn't just a scheduling argument about when we deliver the drug. It's a bioengineering argument about how we deliver the drug.
And that profound realization ushers us directly into the intravenous revolution.
Which brings us to the next phase of the paper, bypassing the gut entirely. We have to talk about cangrelor.
Cangrelor is a monumental leap forward because it takes the wildly unreliable variable of the human stomach entirely out of the equation.
So no more waiting for digestion.
Right. It is a highly potent intravenous P2Y12 inhibitor. It is an ATP analog that binds directly and reversibly to the platelet receptor,
So it's not a pill, it goes straight into the vein.
straight into the systemic circulation. To understand why this is revolutionary, we have to look closely at the pharmacokinetics because the numbers here are just staggering when compared to the oral options.
Okay, let's hear the numbers.
We just established that an oral pill, like ticagrelor or prasugrel, even under normal, healthy conditions, takes significant time to work.
Right.
In a STEMI patient who is in shock, experiencing gut hypoperfusion, it can take 4 to 6 hours to achieve a clinically meaningful antiplatelet effect.
4 to 6 hours. By the time the drug actually kicks in, the catheterization procedure has been over for half a day. The patient is already in the recovery ward.
Exactly. The vulnerability window during the actual stenting is left completely unprotected. Now, contrast that with Cangrelor.
How fast is it?
Because it is administered as an IV bolus and continuous infusion directly into the blood, it bypasses the esophagus, the stomach, the intestines, and the liver. It doesn't need to be digested or metabolically converted.
Okay.
Its onset of action, the time it takes to achieve profound, nearly 100% platelet inhibition, is 2 minutes.
2 minutes. That isn't just fast. In the medical world, that is instantaneous.
It is absolute on-demand pharmacological control, but the speed of onset is only half the magic.
What's the other half?
The other critical factor is its clearance rate. Cangrelor has a half-life of just 3 to 6 minutes in the plasma.
I want to make sure we understand the gravity of that half-life.
Sure.
What does 3 to 6 minutes mean for the surgical team in practical terms?
It means that the drug is degraded by enzymes in the blood incredibly rapidly. The moment you stop the IV drip, the drug begins to clear.
So it fades fast.
Very fast. Within roughly an hour of turning off the infusion, normal platelet function is completely restored.
Okay, let's go back to our analogies. If swallowing an oral blood-thinning pill is like preheating a massive industrial oven, you turn the dial, you wait hours for the heat to slowly build up, and once it's hot, it takes hours to cool back down. Cangrelor is like flipping a light switch.
A light switch,
You
yeah.
flip it on, and the room is instantly flooded with light. You have instant maximum ischemic protection.
Right.
But crucially, if the cardiologist looks at the angiogram and realizes, oh no, this isn't a simple stench job, the left main artery is shattered, we need to rush this patient to open heart bypass surgery immediately, they just flip the switch off.
They flip it off.
They stop the IV, and the drug is completely gone from the patient's system before the surgeons even have time to scrub in and crack the chest. You don't have to wait days for the oven to cool down while the patient bleeds.
That is the exact clinical utility. You achieve maximal immediate protection against clotting during the delicate wire and balloon phase of the procedure, but you maintain ultimate surgical flexibility.
You haven't trapped yourself.
Exactly. You have not chemically backed yourself into a surgical corner.
The light switch concept is brilliant. But let's look at the hard outcomes. What does the trial data say about this instantaneous control? Does Cangrelor actually improve survival or reduce complications compared to the oral pills?
The efficacy of Cangrelor was rigorously tested in a massive clinical program known as the CHAMPION trials.
Okay.
When researchers performed a pooled analysis of the 3 major CHAMPION trials, encompassing tens of thousands of patients, the data was compelling.
What do they find?
They found a 20% relative reduction in major adverse cardiovascular events at 48 hours compared to the oral control groups.
A 20% drop in major events in the first 2 days. What specific events was it preventing?
This reduction was primarily driven by a significant decrease in periprocedural myocardial infarctions and acute stent thrombosis.
So stopping clots right on the stent.
Right. It was stopping those tiny catastrophic clots that form directly on the metal struts of the stent while the cardiologist is actively working inside the artery.
Wow.
And the most vital part of the CHAMPION data, it achieved this 20% reduction in ischemic events without causing a severe or life-threatening increase in major bleeding.
Because if a bleed did start, they could just reach over and turn the IV off. The half-life protected them.
Precisely. The safety profile is dictated by that incredibly short 3 to 6 minute half-life.
But where this IV approach really proves its worth, according to the Euro intervention paper, is in the absolute sickest of the sick.
Yes.
The patients where the oral pills don't just delay their effect, but fail entirely.
We absolutely have to discuss the patients presenting with severe cardiogenic shock. This is the most lethal manifestation of a heart attack.
It's the worst-case scenario.
It is. The heart pump has failed so catastrophically that it can no longer maintain adequate blood pressure to sustain the rest of the body's organs.
Paint a picture of what a patient in cardiogenic shock looks like in the ER, just so we grasp the severity.
It is a scene of organized chaos. These patients are frequently unconscious or delirious due to a severe lack of blood flow to the brain.
Okay.
They are often intubated, meaning a machine is actively breathing for them. Their blood pressure is plummeting, so their veins are flooded with powerful vasopressor drugs like norepinephrine, just to squeeze the blood vessels and keep the vital organs alive.
They're on the brink.
Yes, and their extremities are cold and mottled because peripheral blood flow has been completely sacrificed to protect the core.
You absolutely cannot hand a patient in that condition a glass of water and a pill to swallow.
It's physically impossible. And historically, the medical workaround was just brutal.
What did they do?
Doctors would literally crush the oral ticagrelor or clopidogrel pills into a powder, mix it with water, and push it down a nasogastric feeding tube directly into the patient's stomach.
Assuming that by crushing it, they were doing the stomach's mechanical work for it, hoping it would absorb faster.
That was the hope.
Did that actually work?
We finally got the definitive answer to that question at the ESC Congress in 2025 with a landmark trial called DAMI-T-SHASH AMI.
Oh, I've seen that mentioned in the paper.
Yes, it was explicitly designed to test this exact scenario. They enrolled over 600 critically ill patients in severe cardiogenic shock.
Okay, so a very specific sick population.
Very sick. They randomized them into two groups. One received the instant-on IV infusion of cangrelor, and the other group received crushed ticagrelor pushed down their feeding tubes.
And how did they measure success?
They drew the patient's blood at the very end of the primary PCI procedure and ran it through a lab test to see if they had actually achieved adequate platelet reactivity.
So in simple terms, they checked if the blood was actually thin enough to prevent a stent clot.
Precisely.
What were the numbers?
In the group receiving the cangrelor the fifth, 100% of the patients achieved the target level of platelet inhibition.
100%. The drug worked perfectly every single time, regardless of how sick the patient was.
Every single time.
And the crushed pill group. The patients who had the drug pushed straight into their stomach.
Only 22.1% achieved adequate inhibition.
Wait. I need to pause and reflect on the gravity of that statistic. 22.1%.
It's a sobering number.
That means nearly 80% of the sickest, most critical patients in the hospital. Patients whose lives literally hung by a thread went through a highly thrombogenic surgical procedure with virtually zero pharmacological protection from blood clots.
Yes. For years, surgeons were operating on these patients, assuming the crushed pill was working, when in reality, the drug was just sitting inert in a paralyzed, hypoperfused gut.
It is a terrifying realization.
It really is. The systemic shutdown of the gastrointestinal tract during cardiogenic shock is so absolute that oral absorption drops to near zero. The DAP-SHOCK AMI trial made the clinical reality undeniably clear. For critically ill patients, intubated patients, or patients in shock, the intravenous option isn't just a better or faster method.
Right.
It is the only biologically reliable method of achieving platelet inhibition.
The review also briefly mentioned something called the bridge trial in relation to cangrelor. How does that fit into this picture?
Oh, the bridge trial is fascinating. It explored an entirely different but equally vital application for that light switch flexibility we talked about.
Okay, give me a scenario.
Imagine a patient who had a stent placed a few months ago. They are diligently taking their daily oral ticagrelor to prevent that stent from clotting.
Standard protocol.
Right, but suddenly they develop acute appendicitis or they need their gallbladder removed immediately.
You can't perform major abdominal surgery while they are on potent oral blood thinners. They would literally bleed to death on the table.
Exactly. But if you tell them to stop taking their oral pills a week before the surgery to let their blood normalize, you expose them to a massive risk of their coronary stent suddenly clotting off and causing a lethal heart attack.
So it's another impossible catch-22.
It is. The bridge trial demonstrated how to use cangrelor to solve this.
How does the bridge actually work?
You stop the patient's oral pills a few days early, their blood begins to thicken back up.
Okay, preparing for surgery.
Right. But to protect the stent, you admit them to the hospital and start them on a continuous IV drip of cangrelor.
So you switch the protection method.
Exactly. You maintain a perfect chemically controlled shield of protection over the stent. Then, literally minutes before the abdominal surgeon makes the first incision, you turn off the IV.
The light switch goes off.
The drug clears in 5 minutes, the surgeon operates safely with normal blood clotting, and the moment the patient is stitched up, you turn the IV right back on.
You have bridged them safely across the surgical cast.
Exactly.
That is an incredible level of bioengineering and control over the human body's systems.
It's elegant medicine.
So the IV revolution solves the plumber's catch-22 regarding unexpected bypass surgeries, and it definitively solves the sleeping stomach problem in cardiogenic shock.
It does.
But it still has one massive, glaring limitation. It requires a hospital.
That is the bottleneck.
It requires an IV pump, a sterile line, and a doctor to calculate the dosage. What if we could take the blistering speed and perfect reliability of an IV and somehow engineer it into a device that the patient could hold in their own hand, in their own living room, the absolute second they feel that familiar chest pain?
Now we are crossing into the most exciting territory of the Euro Intervention Review.
The frontier.
We are entering the frontier of pre-hospital care. We are looking at novel parenteral agents, meaning drugs delivered outside the digestive tract that are specifically engineered for rapid, idiot-proof out-of-hospital administration.
Because even with all of our incredibly fast door-to-balloon times, the paper points out a pretty grim, sobering statistic about systemic delays globally.
It does. It highlights a geographical reality that we often ignore when talking about advanced hospital care.
What's the reality?
Even with modern advancements, the data shows that only about 17% of patients who present to a non-capable hospital and require an inter-hospital transfer to a specialized PCI center actually receive reperfusion therapy within the guideline-recommended time frame.
Only 17%.
Yes.
So if you happen to live in a rural farming community, or you are on vacation and show up at a small community hospital that doesn't have a 247 catheterization lab, the logistics of getting you into an ambulance or a helicopter almost guarantee that you will miss the optimal window to save your heart muscle.
That is the harsh geographic reality of emergency medicine. The time is muscle window is unforgiving.
So what's the solution?
If we can't physically transport the patient to the hospital fast enough, we need a way to chemically freeze the clock while the patient is in transit. And since we have exhaustively proven that swallowing oral pills is too slow and unreliable because of the gut shutting down, the pharmaceutical frontier had to move to the subcutaneous tissue.
Subcutaneous, meaning an injection just under the skin, like a diabetic taking an insulin shot.
Exactly. Or, to use a more urgent parallel, like a patient with a severe peanut allergy using an EpiPen.
Right.
The paper details two major revolutionary drugs currently dominating this space. The first one is called selatogrel.
Let's break down selatogrel. Chemically, what is it and how is it deployed?
Selatogrel is a novel, highly potent, reversible P2Y12 inhibitor. It targets the exact same platelet receptor as the oral drugs we discussed earlier.
Okay, so same mechanism.
But instead of being formed into a pill or an IV bag, it has been formulated into a sleek, auto-injectable pen.
Wow.
The clinical vision here is profound. A cardiologist identifies a patient as being at extraordinarily high risk for a recurrent myocardial infarction. They prescribe this auto-injector for the patient to keep in their medicine cabinet or their purse.
And then what?
The very moment that patient feels the crushing weight of a heart attack begin, before they even dial emergency services, they pull out the pen, press it against their thigh or abdomen, and administer the drug themselves.
So they are initiating advanced emergency cardiac pharmacology at minute zero, before the ambulance even leaves the station.
Exactly.
That is incredible. But how fast does the subcutaneous tissue actually absorb it?
Blisteringly fast. The phase 2 data is remarkable. A single subcutaneous injection of selatogrel induces profound antiplatelet effects, with 91% of patients responding adequately in just 30 minutes.
30 minutes?
Yes. It achieves a depth of platelet inhibition in half an hour that standard oral ticagrelor or prasugrel would take several hours to reach, completely bypassing the dormant stomach.
And is it safe? We spent the first half of this deep dive establishing that blindly turning off platelets causes massive bleeding risks if they need surgery.
That is the pivotal question.
If patients are injecting themselves at home, aren't we just recreating the ACOS trial nightmare?
It's a very valid concern. Because selatogrel is a highly reversible agent with a much shorter duration of action than the old oral pills, the early safety profile actually appears very well tolerated.
Oh, really?
Yeah, without triggering a massive spike in major bleeding complications.
Yeah.
However, the medical community is not taking this lightly.
I would hope not.
The true definitive test of this drug is happening right now. The paper heavily features the ongoing SOS-AMI trial.
Tell me about the scale of SOS-AMI.
It is a monumental undertaking. It is a massive, global, double-blind, randomized controlled trial enrolling 14,000 high-risk patients.
14,000. That's huge.
It is. They are rigorously, painstakingly testing whether self-administered selatogrel as symptom onset actually translates to a reduction in early ischemic events in the messy, uncontrolled real world.
If SOS AMI succeeds, it will completely rewrite the algorithm for at-home cardiac care.
It absolutely will.
We are essentially giving patients the power of an emergency room toolkit, but the review outlines a second drug in this frontier space. Let's talk about zoliflodone.
Zoliflodone, which is also known in the literature as RUC4, is a fascinating piece of biochemical engineering because it attacks the clot from an entirely different angle.
Different from P2Y12.
Yes, it is not a P2Y12 inhibitor. It is a glycoprotein IBA inhibitor.
Okay, we need to translate that biology for a moment. What is the functional difference between blocking P2Y12 and blocking glycoprotein IBA?
Let's use a visual. Think of a platelet circulating in your blood as a tiny floating sphere.
Okay, got the sphere.
P2Y12 is a receptor on the surface that acts like an antenna. It receives chemical signals, specifically ADP, that tell the platelet, hey, there's damage nearby, get ready to get sticky.
And drugs like clopidogrel and solitogrel jam that antenna.
Exactly. Glycoprotein IBA, on the other hand, is the actual physical hook that the platelet uses to grab onto other platelets and cross-link with fibrinogen to form the solid mass of the clot.
Ah, I see. So if P2Y12 drugs block the signal to get sticky, zoliflodone just goes in and physically disables the hook itself.
Exactly. It is a more direct downstream blockade of platelet aggregation. Now, we have had intravenous drugs that block this hook for decades. Drugs like apixaban or teriflunomide.
But there's always a but.
But they had major, terrifying problems. Those first-generation IV drugs often caused severe, sudden drops in a patient's total platelet count, a condition known as profound thrombocytopenia.
Why did the old drugs destroy the platelets? I thought they were just trying to stop them from sticking.
It was because of how clumsily they bound to the receptor. When the old drugs attached to the glycoprotein IBA hook, they actually forced the receptor to dramatically change its physical shape.
Okay, and why does shape matter?
Because the human immune system is constantly patrolling for abnormalities. When it saw these violently misshapen receptors, it assumed the platelets were infected or damaged, and it generated antibodies to ruthlessly attack and destroy them.
Wow. So you tried to thin the blood, but you accidentally triggered the immune system to wipe out the blood cells entirely.
Exactly. It was a massive problem.
How is zoliflodone designed to avoid that immune response?
This is where the molecular elegance comes in. The glycoprotein IBA receptor inherently requires metal ions, specifically magnesium, to lock into its active, sticky conformation.
Okay.
Zoliflodone is designed for simple subcutaneous injection by a paramedic in the ambulance. When it enters the blood, it acts as a highly specific displacement agent.
Displacement agent.
It sneaks into the receptor and chemically evicts a single magnesium ion from the binding site.
It swaps out a single ion. That's it.
It displaces the magnesium, which instantly paralyzes the receptor's ability to bind to fibrinogen. It blocks the hook from working, but crucially, it achieves this blockade without altering the macroscopic physical architecture of the cell.
So the receptor shape remains normal.
Precisely.
It's like sliding a microscopic piece of clear tape over the latch of a door. The door still looks exactly the same to the immune system security guards walking by, so they don't attack it. But the door absolutely will not click shut.
That is a phenomenal analogy.
Thank you.
Because it doesn't distort the shape, the risk of triggering that catastrophic immune-mediated thrombocytopenia is drastically reduced, and the clinical data is reflecting this brilliant design.
What data do we have on it so far?
The paper highlights the Phase 3 Celebrate trial, which enrolled nearly 2,500 STEMI patients.
And what did Celebrate prove about the paramedics actually giving this shot?
It demonstrated that a single pre-hospital subcutaneous injection of zoliflodone by an EMT resulted in a clear, statistically significant improvement in early coronary reperfusion.
Meaning it was actively starting to dissolve the clot before the hospital doors even opened.
Exactly. And it did this without causing severe bleeding spikes. It acts in roughly 15 minutes, and it has a very short half-life of about an hour.
That timing is impeccable.
It really is.
The paramedic gives the shot in the living room. The clot starts dissolving within 15 minutes while the ambulance is screaming down the highway. Then the cardiologist places the stent with full protection. And by the time the procedure is finishing up and they need the blood to clot normally again, the drug is naturally wearing off.
It is the ultimate optimization of the pre-hospital window.
If we zoom out and look at the central illustration provided in the Euro intervention paper, this entire decades-long journey we've just discussed is really about shifting a timeline on a graph.
I agree completely.
We are relentlessly trying to push the medical intervention further and further to the left. Decades ago, we relied entirely on downstream treatment, giving the drug at the hospital PCI phase.
Yes.
Then we attempted upstream pretreatment, trying to give oral pills early, but the modern speed of the hospital proved that caused bleeding, and the biology of shock proved the gut wouldn't even absorb the pills anyway.
Right, the stomach just shuts down.
And now, with subcutaneous innovations like selatogrel and zolunfiban, we are attempting to move the therapeutic strike all the way back to the literal symptom onset phase.
You have synthesized a massive, complex paradigm shift perfectly. We are fundamentally attempting to neutralize the thrombotic risk during those highly vulnerable, chaotic hours of patient delay and systemic transport.
It's a huge leap forward.
The era of the blind oral head start, hoping the stomach works and hoping the patient doesn't need a bypass, is ending.
Thank goodness for that.
The era of targeted, parenteral, instantaneously reversible precision is beginning.
And this incredible evolution matters to you, the listener, in a very real, tangible way.
It truly does.
Because if you are ever standing in a brightly lit emergency room, terrified, holding the hand of a family member who is experiencing chest pain, you now understand the incredibly complex mathematical calculus the physicians are running in their heads.
Yes.
When they decide not to give that powerful blood thinner before the angiogram, when they tell you calmly that they are waiting to see the camera footage of the heart first, you know that it is not hesitation.
It's not.
It is not negligence. It is absolute precision. They are actively protecting your loved one from the plumber's catch-22. They are practicing the most up-to-date, evidence-based medicine available.
To conclude this deep dive, I want to leave you with a final thought to mull over, one that stretches beyond just cardiology.
What's that?
If the massive SOS AMI trial succeeds, and self-injectable rapid-onset heart attack medications like selatogrel become as common, trusted, and accessible as EpiPens, how does that fundamentally change our entire relationship with emergency medicine?
That's a profound question.
Well, we are essentially moving the boundary of the intensive care unit out of the sterile hospital, past the ambulance, and directly into the patient's pocket. If we can engineer pharmacology safe enough to trust a terrified patient to chemically stabilize their own coronary arteries at minute 0 while sitting on their living room couch,
Wow.
what else could we treat at minute 0?
Wow.
What other deadly emergencies are just waiting for a biochemical key to freeze the clock?
Thank you for watching The Funnel Effect.